Welcome. My name is Rob Lott, and I am a deputy editor here at Health Affairs. I'm delighted to welcome you to the latest in our series of Lunch and Learn discussions from Health Affairs, and the first in our collaboration with the Society of Health Policy Young Professionals, also known as SHPYP, the premier professional development organization for health policy young professionals in the DC metro area. We're grateful for their partnership, and folks should stay tuned for more details about how you can get involved with SHPYP if you're interested. Our conversation today is about the health implications of food insecurity. They are deep, far-reaching, and complex, especially when it comes to the needs of older adults, especially amidst a global pandemic. By now, I think there's a broad understanding and consensus that social determinants have a profound effect on people's health, well-being, and ability to thrive. And the role of food insecurity is perhaps exhibit A in plainly illustrating exactly how that pathway operates. Less clear is what exactly to do about it. What is the right balance of investment? What is the best kind of intervention, the one with the strongest evidence or the greatest promise? What kind of institution or organization should we be enlisting to lead or manage this work? These are hard questions. Obviously, there's no way we will answer them definitively here today, but I can't think of anyone better to continue digging deeper on these questions than the three very special guests we have here today. In a moment, I will introduce our speakers. First, Dr. Powers and Stephanie Franklin will present their work, and then we'll bring in Dr. Peak to offer perhaps another perspective. And then from there, we'll have a conversation and some questions from me and all of you out there. You can submit questions at any time during today's event using the Q&A box through Zoom. We will try to get to as many as time allows and focus on topics that are of interest to the most people. As with other health affairs events, this session is being recorded, and the video will be posted to healthaffairs.org in the coming days. Now, I am honored to introduce our guests. Brian Powers currently serves as Deputy Chief Medical Officer for Humana. Dr. Powers previously worked as the Director of Population Health Strategy and Analytics for CareMore and Aspire Health at Anthem. Brian has continued to work as a practicing internist at Brigham and Women's Hospital and at Atrius Health. Stephanie Franklin is the Associate Director of Population Health Strategy, supporting Humana's bold goal to improve the health of its members and communities by developing and integrating solutions that address their unmet social needs. Stephanie joined Humana in 2014. Previous roles included leading clinical programs aimed at preventing and delaying progression of chronic disease. Monica Peak is a professor of medicine at the University of Chicago and associate director of the Chicago Center for Diabetes Translational Research. She specializes in general internal medicine and preventive health for adults and has a particular interest in reducing healthcare disparities. Dr. Peak concentrates her efforts on diabetes care and breast cancer screening education for African American patients, and on how racial and cultural barriers impact physician-patient relations and shared decision-making. With that, I will turn things over to Brian and Stephanie, who served as co-authors on a study published in the April 2022 issue of Health Affairs titled Health-Related Social Needs Among Older Adults Enrolled in Medicare Advantage. Brian?
Great, thanks, Rob, and thanks for everyone for joining us today. We're excited to get the opportunity to share some of our research and some of what the work we're doing at Humana to address food insecurity and other health-related social needs. If you wouldn't mind going on to the next slide. So as Rob mentioned, Stephanie and myself and some of our colleagues at Humana published a paper in Health Affairs in April in which we shared data on the health-related social needs of our members, so older adults enrolled in Medicare Advantage plans offered by Humana. And I'm going to take the first few minutes here to run through some of the high-level results from that paper, and then turn it over to Stephanie, who's going to talk more about how we use this data internally to better serve our members and impact their health. And so a quick overview of the data we used for this analysis before we get to the results. And so I think it's important to note that we conducted this analysis, this research, not for research's sake necessarily, but really to improve the way in which we can care for our members. But we found that it was sort of very illustrative and illuminating data and wanted to share it more broadly. And so the survey that you'll see that we report results from was a survey that we sent to about 400,000 of our Medicare Advantage members at the end of 2019 and into early 2020. And so important to note, it wasn't by design, but we did sort of sneak in just before the COVID pandemic began. I think that's important for a couple of reasons. As Rob alluded to at the outset, we know that the COVID pandemic clearly impacted health-related social needs for everyone, including older adults. And so important to think about these results as a pre-pandemic baseline. And Stephanie and I can maybe speak a little bit to how we saw things change over the pandemic, but just so you know, everything you see here was before the pandemic. And as I mentioned, about 400,000 survey, if you don't mind going back for just 1 second, 400,000 or so members, about 25% of whom responded. So we're looking at about 100,000 of our Medicare Advantage beneficiaries, and this was a national sample. We looked at 7 different health-related social needs, which you see up here on the screen, and I won't read through. And for those of you that are well-versed in the various ways to measure and assess for health-related social needs, you'll probably be curious, what instrument you used and how we assess this. We used a very slightly adapted version of the CMS Accountable Health Communities Survey. And so the specific wording for these different questions, should you be interested, is going to really closely mirror what CMS uses in that instrument. So onto the results, if you don't mind going to the next slide. It's the sort of headline result is the overall prevalence or incidence of health-related social needs. And we found that among those survey respondents, so among those 100,000 Medicare Advantage beneficiaries, about half, 49%, reported at least one health-related social need. And what you see here is the distribution among those who at least reported one. And you'll see that the majority that had any health-related social need had more than one. And I think, there have been little slices of the assessments of the prevalence of health-related social needs among older adults. And I think, our goal here was to conduct a more comprehensive survey, a more comprehensive assessment. And I think, the overall burden is striking. I think sometimes folks don't realize the degree to which our older adults experience health-related social needs. And so this finding alone, I think, is just a clear mandate for the system at large to better understand and better address these needs, affecting, again, 1 and 2 older adults. If you don't mind moving on to the next slide. So what were those specific needs? That's what the figure here from the paper shows. And we saw that, 3, by far the most common was financial strain, with about 33% of, this is overall respondents, so not just among those who reported a need, 33% of Medicare Advantage beneficiaries reporting financial strain. The questions usually worded around difficulty paying for the basics. And then the other 2 that were most common were food insecurity, which is a focus of today's discussion, and poor housing quality. And then you'll see the other 4 kind of trailed off a little bit. If you don't mind going on to the next slide. Another area that we focused in on, actually at length in the paper, if you're interested in learning more, is what demographic characteristics are associated with higher or lower rates of health-related social needs. And what we found is that there were significant disparities in the prevalence of health-related social needs across race, socioeconomic status, sex, geography, and other characteristics. And I'll highlight a few here, focusing in specifically on food insecurity, given the focus of today's discussion. And so if you look at that second column there, you see that the overall prevalence of food insecurity was about 18% in our sample. And then if we kind of work down the rows, looking at different groups of beneficiaries, we see that food insecurity was more prevalent among younger individuals. That can be a bit of a head scratcher. We think what's probably happening there is what the epidemiologist in the room would call survival bias. If you experience significant food insecurity, you are unfortunately less likely to live longer. And so that is probably what we're seeing there in that trend within the age groups. Moving down, we see higher rates of food insecurity among our female members than our male members, about a 1.25x or 25% higher rate. And that holds true across a lot of the different needs, but is most notable or more notable among food insecurity. As we see with really all the needs as well, but again, especially food insecurity, really striking and unsettling racial disparities. We specifically looked at Black-white disparities due to some limitations in the data that we had access to for other races. And you see here over the prevalence of food insecurity among the Black members is over twice that of our white members. There were not necessarily striking regional or urban-rural disparities in this specific health-related social need, I think, nor were there clear patterns across all of them. If you kind of squint and look at some of these, you can pick out specific trends. I think the takeaway here is that the burden varies by need, by geography, and by population density, but it's not, you can't just say that health-related social needs are more common in urban areas than rural areas, or more common in the South than the Northeast. It really depends a little bit about which specific need you're looking at. And then the final demographic area to highlight is around socioeconomic status. We looked at that in two ways. We looked at it by comparing individuals who are eligible for Medicare's Part D low-income subsidy, so those who qualify for extra help affording their prescription drugs. And then we also looked at individuals who are dually eligible for Medicare and Medicaid. And so for both those measures of socioeconomic status, we find, again, really striking and alarming disparities in the prevalence of health-related social needs, with about 3 times as many individuals who are either eligible for the low-income subsidy or dually eligible for Medicare and Medicaid experiencing food insecurity. Those types of disparities hold across really all of the health-related social needs, as you'll see here, and are pretty much persistently about anywhere between 2, 3, 4 times as prevalent among those at a lower socioeconomic status. One thing that's not shown here that I think is important to remember, which is although lower socioeconomic status is associated with a really striking increase in the likelihood of experiencing a health-related social need, the majority of members with health-related social needs are not actually eligible for the low-income subsidy or duly eligible for Medicare and Medicaid. And so while socioeconomic status confers a much higher risk of experiencing a health-related social need, we can't just focus on those individuals if we're hoping to address health-related social needs. In fact, 75% of the individuals reporting a health-related social need in our survey were not duly eligible for Medicare and Medicaid and were not eligible for the low-income subsidy. So while we have to direct disproportionate attention to those individuals, we can't lose sight of the fact that the broader population also experiences a high burden of socioeconomic status. And with that, I will turn it over to Stephanie to talk a little bit more about how we use this data internally to better improve the health of our members. Stephanie?
Thank you so much. We can go to the next slide. And so I am on Humana's Bold Goal team in the Office of Population Health. And as Brian said, we didn't do this research just for pure research sake. We were really looking for actionable insights for how Humana as a health plan could improve the health and the quality of life of our Medicare Advantage members. So a few intents upon doing this survey. One was, we have been focused on food insecurity for a number of years, piloting new benefits and interventions, partnering with physicians, community organizations. And really, we did realize through this that social needs don't occur in silos. We would talk to someone about their food insecurity, but they had transportation barriers to not only getting to the doctor's office, but getting to a food pantry or a grocery store. Often financial strain is the root cause of food insecurity. We found that loneliness was really pervasive and inhibited individuals' ability to address their other social needs. So we really wanted to understand, how do we screen for social needs in a comprehensive and standardized way, and also at scale? Humana has nearly 5 million Medicare Advantage members across the country. And as Dr. Powers mentioned, we can't, we knew that not everyone with a social need was on a DSNP plan. So we needed to understand what is that distribution of need, and then what is the cumulative burden of those needs? What are the trends in social needs interacting with one another and co-occurring, so that we could better tailor our benefits and care management programs to address those needs. So, from this, we have done a few things in addition to just, sharing these insights and what we've learned through research and opportunities like this. But we've provided those kind of point of care insights to our own clinicians who are leading care management programs, to physicians who are treating our members, to let them know about the social needs that their patients may be experiencing, so they can build those into the care plan. We are also screening in a standardized way across the enterprise, so that both we can understand care in that sort of one-on-one patient management interaction, what needs to be addressed, and get them connected with appropriate resources and interventions, but also so that we can aggregate the data and understand from a population health perspective how we're doing in addressing the whole health needs of the members that we serve. One interesting opportunity that it might be, relevant to a policy perspective, or that CMS has recently, in the last few years, given Medicare Advantage plans new flexibilities to individually tailor benefits to address the health and the health-related needs of our members. So some of these are called the special supplemental benefit for the chronically ill. There's been some additional flexibilities from the CMS Innovation Center with the value-based insurance design program. But both of these programs, while they allow us to tailor benefits based on social need to some extent, we really have to understand what size of a population, what types of needs are relevant, what type of chronic conditions and social needs might be related and exacerbating health outcomes. So we have used this to help us better tailor those benefits and programs that we can offer officially through the benefit design. I'm going back to COVID and the context that immediately after we conducted this survey, a pandemic hit. I also want to note that we've leveraged these screening results to build analytic tools to allow us to understand what types of members are at risk of having these specific social needs. So we've integrated those into our the way that we kind of identify members for outreach and care management. And specifically during the pandemic, we were able to leverage these sorts of insights to quickly identify and reach out to our Medicare Advantage members who we thought might be at risk for food insecurity. Through this and our basic needs program, we were able to deliver over 1 million meals to at-risk food insecure Medicare Advantage members during the first year of the pandemic. And so things like that can make it enable us to really tailor the right intervention and support to those members who are in need. Finally, two last points. Sorry. One is that, again, going from a policy perspective, you all may be aware that CMS has been considering integrating things, thinking about integrating screening for social needs, intervening for social needs into the way that health plans and also providers and hospitals are held accountable and even paid. And so we have used these sorts of data, particularly because we are leveraging the CMS Accountable Health Communities screening tool. We've been able to engage more on these conversations to help inform policy making, both with CMS and with our partners across the industry, so that we can hopefully build a more equitable health system to meet the needs of seniors throughout the Medicare program and Medicare Advantage. And I would be remiss not to call out the importance of our communities. The Bold Goal program has a really deep focus on community collaborations. So again, by understanding the population health needs and the prevalence of social needs in not only nationally, but in the communities that we serve, it really helps us better identify who are the partners that we need to be working with to meet the needs of our members. Where can we partner to build community capacity to meet these needs? Because, you know, through all of these screening and referrals in the healthcare system, we really are cognizant of the importance of those existing social service providers that we need to work with to address those needs. All right, and the next slide is just a few resources, because we could, Dr. Powers and I could talk on and on, but just to point to our population health website, Humana's research website, and then a couple recent publications from some of our colleagues around food insecurity interventions and non-emergent medical transportation interventions that might be of interest to this group. So thanks, Rob.
Thank you so much, Brian and Stephanie. What a excellent presentation. And now I'd like to turn things over to Dr. Monica Peak, who was co-author of, among many publications, a 2021 Health Affairs Forefront article titled, "As They Take on Food Insecurity, Community-Based Health Organizations Have Found 4 Strategies That Work." With that in mind, we're eager to hear her thoughts and reflections on Brian and Stephanie's presentation and this topic more broadly. Dr. Peak?
Great, thank you so much for having me. And so what I was going to do is sort of summarize some of the work that we're doing around food insecurity that was mentioned in the blog that we wrote, but I did want to respond and thank you for the work that you did. And 2 things came to mind. One regarding your the differences that you found by race. And I think that what strikes me is that that's a reflection of structural inequities or structural racism. And so on top of the income disparities that result in differential prevalence in social needs, we also see the impact of structural racism. And so that also means that as we're thinking about tailoring our interventions, not just for specific chronic diseases, we also need to be tailoring them for specific populations and the specific needs and preferences that they may have based on their lived experiences with discrimination, with immigration, with whatever happens that may affect how they are able to interact with our healthcare systems, with our non-healthcare systems that ultimately impact their health. And so as we are thinking about providing food or providing shelter, what are the external contexts in which people are living that make that possible or less than possible? And so thank you. Super excited about your work. And so I'll just sort of briefly summarize some of the interventions from some of the teams that we're doing, and then I'd like to open it up. So this is just data from Feeding America about some of the underlying drivers of food insecurity. And thank you for acknowledging that food insecurity is really an economic issue. So I'm showing the annual unemployment rates and poverty rates and predicted food insecurity rates and the number of food insecure people for 2018. around 50 million, and that was actually projected an increase from around 35 million. But the numbers that we saw around the start of the pandemic were related to the economic crisis, and some of that was as related to they were intertwined with the pandemic itself. Next slide. And so me, as a diabetes researcher and internist, I think about food insecurity for a lot of reasons, but also because of its impact on health. And we know that it's associated with poor diabetes self-management and increased odds of poor diabetes control, and preventable hospital admissions and lower extremity amputations. Next slide. And so I'm one of the co-directors of the National Program Office for a program called Bridging the Gap, Reducing Disparities in Diabetes Care. And we have 8 sites across the country. And so I think it was interesting that you all noted that that the unmet needs really didn't vary that much based on rural versus non-rural, Southern versus Northeastern, or wherever. And so we have sites that are across the country that have a very heterogeneous portfolio as far as patient demographics, frontier versus and urban, and all kinds of areas of the country. Our goal is to build sustainable partnerships, bringing medical and social care together, and to redesign healthcare systems to provide holistic diabetes care and ultimately improve the health of marginalized populations who have type 2 diabetes. And that includes thinking about things like food insecurity, which is what I'll talk about here. Next slide. And so we have identified 4 successful strategies that some of our member organizations or member sites have done to increase food access for disadvantaged or marginalized populations. Next slide. The first would be embedding food distribution within hospital settings or clinic settings. The advantage is that it can provide rapid food provision for patients with urgent needs for food that day. It can decrease the patient burden via the co-location of services, so they're not having to make multiple trips to different sites. And it has the opportunity to link things the hospital are good at, healthcare skills like nutrition education at the same time. It helps to build institutional trust, which is something that we've seen through the COVID pandemic that healthcare institutions really don't have a whole lot of, and needs to do a whole lot of rebuilding in. Next slide, please. So one of our sites is the Roots Community Health Center. They have a choice model for food selection, so it's like grocery shopping, and they use a point system for foods, which sort of incentivize or prioritize choosing healthy food. And during the pandemic, they saw a 500% increase in the distribution of volume number pre versus during the pandemic. And so that's a sort of the map, or the graph that you see on the left, sort of the time period from June of 19, so right before the pandemic started, March of 2020, and then from the big March of 2020 through the December of that following year, the number of food distributions and the number of people served increased significantly. Roots Community Center also has Welcome Wednesdays, where hot meals are prepared and they're open to the public, and they can come and learn about the various resources that are available to the clinic. And that's another way of providing sort of social capital and building trust with the community. Next slide. Another site that we have is Providence Milwaukee Hospital. And what they also have is a community teaching kitchen, which is located physically on the campus of the hospital. They provide nutrition education. They have a state-of-the-art kitchen. And there in that place, they provide a range of all their navigation services. And it's physically sort of steps away from the family medicine clinic. And so people come there. It's like their local Starbucks in some ways, where people come to hang out and meet friends. They can also learn how to cook some of the various foods that are being distributed, and they can get services for a variety of unmet social needs. And during the pandemic, they partnered with Ride Connection to be able to deliver food to people who weren't able to come in because of the pandemic. So this is just a snapshot of what happened from April 2020 to April 2021, the amount of pounds of food, the number of meals, and the number of individuals that received food during that year from the community teaching kitchen. Next slide, please. So the second strategy, and I talked a bit at the beginning about the need to tailor based on the population. So tailoring food access programs, specifically in this case, to addressing systemic barriers for immigrant populations. And so we already know that many of the federal programs, you guys did an analysis for Medicare. So many federal programs like SNAP or Medicaid don't serve all immigrants. And there is a fear about the public charge rule. So that is one issue that some immigrants are concerned about. Private sector resources often may not be tailored to the literacy, the linguistic needs, possibly the literacy needs, but also the sociocultural dietary needs that people coming to this country may have. And so fresh fruit and vegetables are always needed, but if they're not the ones that people are used to getting at home, they may not know how to incorporate that into how they're used to preparing food. And so what one of our sites did, the La Clinica del Pueblo Community Health Center, is they were doing universal food insecurity screening, and they referred them to trusted community partners. And one of the main ones was a place called Fresh Farm. And what they did is they specifically provided low-cost fresh produce for immigrants who were SNAP ineligible. So made it a sort of a very specific niche of people that really matched a lot of the population that this clinic was serving. During the pandemic, where a lot of people were not able to sort of, again, go out, the clinic itself served as a safe space, an emotionally safe and a physically safe space for patients to come and not only sometimes see their providers, a lot of that was done by telehealth, but to receive bags of food. And additionally, bags were distributed that had not only food in it, but COVID safety information about the sort of health of COVID, but also a know your rights information. So there was a lot of, I don't know if people can remember, during the pandemic, a lot of concern about ICE raids and things like that, and people being shipped or, taken back to countries of origin. And I live in Chicago. And so there was a lot of concern here as, a city that was a city of protection, that was going to happen even here. And so as we think about immigration as a social need sometimes that people need to be thinking about, then they were addressing those needs at the same time as food insecurity. Next slide. A third strategy was thinking about addressing food insecurity while bolstering communities' economic vitality. And so this was one of our sites in rural Kentucky. And so getting back to the idea that food insecurity is often related to economic security and the fact that many people have inadequate wages. We in this country have really not decided that a livable wage is something that we're comfortable with. And so if we can support local economies while feeding hungry people, then we have the potential to address both individual level and community level poverty and food insecurity at the same time. So the Mountain Comprehensive Health Corporation, again, in rural Eastern Kentucky, was a partner of what is called the pharmacy program. And so it involves a lot of local farmers in a farmer's market, a community kitchen, incentives for WIC and SNAP for patients to make healthier choices, community health workers, and a hospital food prescription program. And so over 5 years, an external analysis showed that the economic impact of that program alone was almost $3 million for the local community impact. And that every dollar that was spent through this program recirculated in that community 1.5 times. And so during the pandemic, this is a picture of one of the community health workers doing a home visit. The lady with the apple is a patient with diabetes. And so they were doing porch visits. So they would, rather than going into the home and doing what they would normally do, they would visit their patients because people normally had houses with porches in the South. So they would do porch visits and also deliver food. And so that is another way of thinking about food insecurity, is not just thinking about the individual, but thinking about the community as well. Next slide, please. And the fourth is advancing cross-sector collaboration. A lot of times when we think about cross-sector, we're thinking about combining a healthcare system with a non-healthcare system, so a food pantry with the hospital system. But really, to address these pernicious problems, we need to be thinking about multiple sectors for any social need that we have, food insecurity being just one of them. So thinking about food policy, who's eligible for SNAP, what kind of changes can we make in our WIC programs? I talked a lot or a bit about food and nutrition education and cooking, economic development, which has sort of at its core issues of structural inequities for access to education and employment opportunities, food delivery system as far as food banks, pantries, and our regular food system. I was listening to NPR maybe about 2 weeks ago, and I can't remember what country it is, but they have decided to make their grocery stores pay as you go, pay what you can. And so, because they're like, we don't have a limitation of food in this country. We have just decided that some people shouldn't get it because they can't afford to pay for it. And so they have changed their model of food delivery. Rather than letting food rot in the store, they're going to just make sure that people can just, if they don't have any money, they don't pay that day. And so we have to think differently about food insecurity and what that means. And so there's a team in Trenton, New Jersey that has pulled together what they call the Trenton food stakeholders. And it's a lot of different people, community health workers and people from the health department and a lot of different stakeholders who are coming from all these 4 different areas, and they have, supplies and equipment, but some of their challenges are some of the food delivery mechanisms and the ability to sort of maintain the cold chain. That's always the challenge. But what they have done is the ability to sort of identify gaps and try and fill those gaps to be able to help get food to people in real time. And during the pandemic, what they did was develop an interactive map and directory to say that that was open to the public. So people could say, hey, here's some food right here, right now. And people could identify that and try and access that food. So just understanding, I'm sorry, I'm looking at the chat. But this just sort of recognizes that any of these social needs, including food security, are extremely complicated. And so we can try and simplify them to sort of think about them, but really they take a lot of work to address. Next slide, please. And so just finally, thinking about addressing the long-term consequences of the pandemic, the economic, the physical, the emotional, the mental, that have disproportionately impacted marginalized populations, that have sort of piled on top of the structural inequities that already exist, is going to require that payers and healthcare organizations play a pivotal role in addressing patients' unmet social needs. It is truly an honor to be on this panel with Humana and others who have been sort of doing this work and taking on this work. And I'm really looking forward to our conversation. Next slide. So I just wanted to give a shout out to the core team at our Bridging the Gap National Program Office, and again to our 8 sites that are across the country doing this incredible work. Next slide. All right, that's it.
Okay, thank you, Dr. Peak. With that, we will move on now to some Q&A. Viewers can submit questions at any time during today's event using the Q&A box through Zoom below, and we will try to get to as many as time allows and focus on topics that are of interest to the most people. Let me start with a question for Brian and Stephanie, and this is maybe a multi-part question. One, is this the first time that Humana has asked these questions in this form, or what about the approach that you took with this study represents new information for your organization? And then I guess part 2 would be, how have you approached this since the pandemic? Stephanie, you mentioned some of the new analytics, but I'm wondering if you're sort of thinking about your research and evaluation approach going forward in this sort of COVID and post-COVID period going forward.
So, to the first part, we have been screening for food insecurity and loneliness for a number of years using the Hunger Vital Sign and the UCLA three-item loneliness scale for those who like screening tools. And, we have been doing those in pockets a little bit across population, but mostly as a way to identify individuals who were in need of assistance or to participate in an intervention. And like I said, we did realize that screening for one social need at a time didn't give us the full picture of what was going on and how we could best help address those needs. So with this test for the first time, we surveyed really in a concerted and structured way across a number of domains. And since then, that's the model that we have scaled throughout our care management programs and other member touch points, not just asking like, what about your food insecurity, but asking across about 5 domains on a regular basis so that we can address holistic needs and make sure that we're tailoring the interventions to meet those specific needs and barriers.
Maybe I can jump in quickly on the kind of what we've seen with some of the subsequent surveys. So a subset of that population that we shared results from, we then went on to survey every quarter during 2020, or I think it's easy to get your years mixed up at this point, but during 2020. So we had that baseline just before the pandemic and then the other 3 quarters in 2020. And we saw, I'll speak for myself, probably actually a little less movement than I thought we'd see. And I think it's important to remember that our senior population is vulnerable in some ways and less vulnerable in other ways. And so often living on, fixed income and, expenses look a little different. And so I think there's clearly not generalizability about how the impacts of the pandemic on social needs for seniors does not look the same for everyone else. But we did see, so while we didn't see at the population level, we actually saw a similar overall prevalence of health-related social needs across all 4 quarters. So it's not like overall needs really crept up during the pandemic, but we saw a lot of kind of dynamism beneath the surface where about 20% of individuals would go on to gain a new need or have their need resolved. And so I think for us, what that really meant is that you can be fooled sometimes by the population level stability. So, okay, throughout 2020, about 50% of our members experienced a health-related social need, but that does not mean that those needs are static. And so for us, it's thinking about, like Stephanie said, getting data at each touch point, thinking about who's most vulnerable to have a change in their needs. And that, we certainly can't collect data constantly all the time, but that sometimes these, single year or single point in time collections is not going to reflect where a member is in the next 3 months.
Great. At the risk of maybe making things a little awkward, I thought I might put you all on the spot and ask you each to talk about one another. In other words, Dr. Peak, I'm curious how your organization and your partners see the role of payers like Humana in confronting these issues. And Brian and Stephanie, how does Humana think about the role of community-based organizations in addressing the unmet needs you've identified?
Yes, so for us, it has been critical. We have working with payers, trying to work with payers, identifying strategies has been, if not the second most important part of the work that we do, because we're trying to think about sustainability. And so it is, what the grant funding has done, we've been funded by the Merck Foundation, is give us the opportunity to play around and to show the value added. And now to say to the institutions and to the payers, hey, did you know that we just saved you a ton of money, or that we've reduced this, hospital readmission rate, or we've improved this, or, that we've had, these great outcomes. Would you be interested in investing in that? And so that has been one of our priorities, because we have to think about the long-term sustainability. And so one of our sites is in Maryland, so an all-payer state. And so they have been sort of ahead of the game in how they have been thinking about doing this work already before we got here. And so they've been very, just very savvy in all of this. But yes, we love payers because that's going to be what ultimately keeps this work going.
Yeah, and as I said earlier, from our perspective, the communities and community-based organizations are fundamental. We don't want to displace or try to build something new when there's already someone on the ground that's been doing great work addressing social needs. So, for a number of years, I mean, even predating the bold goal and our concerted community focus, managed care organizations, Medicare Advantage specifically, have been tasked with care coordination and addressing whole health needs, though it is in more recent years that there's more of an acknowledgement on social determinants of health, and there's more of a thought about how do we incorporate these types of traditionally social services into a health plan benefits package. So it's very important to us to not just refer, but to think about your sustainability and how that contributes to the sustainability of the system, because we do understand how important social needs are to health outcomes and long-term healthcare costs and utilization, all those things that we're accountable for. But the relationship definitely varies based on the interest of the community-based organization in kind of moving along that continuum, the formality of it becoming a benefit. There's a lot of legal stuff, there's a lot of all like technical stuff, but we've had a lot of rich and relationships with CBOs nationally and locally to do this work.
Yeah, there has to be the infrastructure of people and places and spaces to address these needs, and someone's got to pay for it, so there's a role for everyone. Absolutely.
Yeah. And fortunately, our research and data assets or analytic assets, I think, are a benefit to all of us, and that there is an evidence base, a growing evidence base, but our collaboration allows us to continue to feed that and build that, so that we can say more clearly, by addressing this social need in this way, we're leading to this health outcome.
Absolutely. You have so many patients. It's the magnitude of your data just shadows what individual researchers have the access to.
Great, a lot of potential there. I am going to do my best to get through some of the viewer Q&A. We've got about 10 minutes left. I'm going to start with one question that asks, how might race and ethnicity data be used to inform social health interventions? And I might add just an editorial comment. Monica, you started off by pointing to systemic racism as sort of one of the root causes driving food insecurity. And I think it's fair to say that over the last 2 or 3 years, certainly during the pandemic, there's sort of a broader societal recognition or understanding of the role of systemic racism in shaping people's health. And so I'd be curious to hear everyone's thoughts on sort of how that has changed your approach, how it's changed the approach of the organizations you work with and your work directly.
Yeah, thank you for your comment, and thank you for the question. And I'm secretly wondering if that question is coming from like one of my this work group that I'm with. So we're writing this paper on this very same thing. So I'm like, Carolyn, is that you? So what we've done is take a look at a systemic review of social care interventions and gone back and looked to see how many of them have specifically looked for race, and look for heterogeneous treatment effects by race? Did they even mention race as a social construct? Are they thinking about, you know, the impacts of structural racism and how that may play out for differential, you know, needs, and were the interventions tailored to specifically meet the needs of people of different races and ethnic groups? We were disappointed with our findings. I suppose that's all I can say about that until it comes out. But I think that that is a wake-up call for all of us who are doing this work, to think more critically about this overlay between you know, distinct needs that people have, and how many of those needs are driven by structural racism in our country. And a lot of times these are two different buckets, you know, but these are overlaying, just like we had to kind of have a come to Jesus moment about quality improvement and health disparities, and realize that we move faster when we overlay those together. We can't be thinking about improving health systems and separately over here thinking about health disparities. The work to improve the quality of care we deliver has to always be thinking about health equity. And so the work that we're doing to think about social care intervention, social needs intervention, has to always be thinking about how those may differ for differential populations who have different needs, you know, who are coming with different kinds of, so imagine someone just flew here from Ukraine, right? What kinds of trauma might they be experiencing? And they would have different needs than the average, you know, person who may look just like them with white skin and is showing up at a food pantry. And so we have to think about, but the same is true for African Americans. We just look different, you know, but we've had generations of you know, inequities because of how we look, that have affected our lived experience and how we respond to something. There was a question someone had asked me about, well, if you have a housing voucher program, would you expect that, you know, there would be differences? And I said, there may not be, but I might expect that there would be. If you give two low-income persons a housing voucher and one is Black and one is white, and we are still finding studies that show that there is active racial redlining in this country still, then that Black person probably will have a harder time finding housing. And so that program may not be as effective for African Americans as it would be for people who are non-Hispanic whites. And so I do think that we should be looking for differential treatment effects by race to see, you know, and we should be trying to mitigate those by doing differential interventions that are tailored to different needs and preferences of different groups.
Brian, Stephanie, how have you approached this?
I offer one thing. I think it was such a great point that you brought up initially, Monica, and then emphasized there that it's not, the racial disparities we see are not just about income, and it's sort of buried in an appendix in our paper just because we're limited in what we could share. But if you look, I went and pulled it up while you were speaking. So the food insecurity, for instance, is, if you don't adjust for anything else, you know, is 2.6 times more common among our Black members than white members. When you adjust for everything else, including dual income or dual eligibility status and low income subsidy, it's still 1.6 times higher. So it's not, I think people can be quick to say it's just the, you know, the correlation between socioeconomic status and race, but it's more than that. There's other elements of structural racism and other structural barriers. So it speaks to the fact that you do have to have tailored interventions. I think, generally speaking, you know, we find that interventions, in the few examples where it has been sort of decomposed by race, that I'm aware of at least, that interventions to improve the affordability of healthcare fall disproportionately in a good way to Black individuals due to the higher burden of cost barriers, but it's not the only solution. And so I would just really emphasize and echo what Monica said, that if we want the interventions to be effective, they need to be tailored to the context where people live in their lived experience, and that we need to pay special attention to specific domains of disparities, and that this is not just sort of an income dynamic.
And I know we're getting close to the end, so just a quick addition. You know, as my team is evaluating and testing ways to address these social needs, even though we're a national plan and being able to scale something nationally is important for sustainability, we're trying to look for interventions that allow individual choice in how they access the food. For instance, choice between we'll send you meals versus groceries versus assistance to purchase food, things to kind of build that in to meet individual needs as they are. And then, you know, while we always viewed the work that we do to address social needs as health equity, as furthering health equity, Humana did establish the Office of the Chief Health Equity Officer last year, and I think they just celebrated their 1-year anniversary. So we've been proud to partner with them to have them push us to be even more intentional as we structure clinical and social interventions to make sure that we are acknowledging and factoring in race and inequities throughout. So.
Great. Well, that's probably a good spot to wrap up. I wish we had more time to address a number of the questions in the chat. I'm comforted, though, by the fact that I think a number of them were addressed sort of in the course of our conversation and presentations. But I want to thank everyone for their wonderful questions. And of course, we are so grateful to Brian, Stephanie, and Monica for taking the time to talk with us today. I want to thank again the Society of Health Policy Young Professionals, a nonpartisan volunteer-led organization. Today's Lunch and Learn is the first in a series of programming hosted by Health Affairs and ShipYip. While this first event was open to the public, the following events in this series are for ShipYip members only. If you are not a member, we encourage you to join for only $25 a year at dchealthpolicy.org. If you have any questions, you can email ShipYip at info@dchealthpolicy.org or follow on Twitter at dchealthpolicy. Thank you as well to our Health Affairs team, including Debbie Boylan, Sarah Kolk, the entire Health Affairs editorial and digital teams. If you liked this Lunch and Learn, visit healthaffairs.org to sign up for other upcoming events and join our email list to learn about them as soon as they are announced. Thank you again to everyone for joining us here today. And with that, we are adjourned.